Okay, well, I would like to welcome everybody to our May Public Health Preparedness webinar. This is going to be the last webinar that we have of this academic year, so thank you all for coming. We've got a really great speaker tonight. Before I turn it over to her, I just want to make a couple quick announcements, and then I will turn it over to her so then we can talk about the National Guard's role in public health emergencies. So first of all, for any of our students who are going to be at commencement, congratulations! We are so proud of you guys. But we are going to have a number of faculty members there. So if you will be graduating, we look forward to seeing you in just, I think it's 10 or 11 days. So congratulations again, and we're really looking forward to that. Our next International Association of Emergency Managers student chapter meeting is going to be on May 17th. If you are interested in attending and you don't get the meeting invites, please reach out to me or reach out to JD Tooney. You can also check out our Penn State IAEM site. Just reach out to us and we can get you any of that information. We're trying to have another IAEM speaker in May, and we're also going to be talking about the CEM packages and all that kind of stuff. So the public health preparedness webinars that we do are going to stop for the summer. The IAEM meetings are going to go all through the year. So we are going to be resuming our PHP webinars September. So it's thanks JD for posting the IAEM site that's going to have all that information. So our next public health preparedness webinar is going to be Wednesday, September 7th. It's always the first Wednesday of the month at 8 p.m. Eastern. So September 7th is going to be our next one after this. And final announcement, as we roll into the fall semester in September, we are planning on opening up the school store again. So if there's anything that you want, just hold out for the summer, and then we will be opening it up right after fall semester starts. That way we can get all of the new students that we have coming in. So those were the only announcements that I had. We've had a really great bunch of speakers for this academic year, and I am excited to be able to wrap it up with Jamie tonight. So as I mentioned, and as you can see from her slide here, she's going to be talking about the National Guard's role in public health preparedness during the COVID-19 pandemic. And she is coming to us with a really interesting background, as I am having trouble scrolling this. So she currently works at the Air National Guard as the Air National Guard COVID-19 Public Health Officer in the role of the Air National Guard Surgeon General, Joint Base Andrews, Maryland. In this role, she serves as the lead COVID-19 advisor for 90 Air National Guard units across all 54 states and territories. She is also a part-time third-year Doctor of Public Health candidate at Johns Hopkins University, working on her degree in the Environmental Health Concentration Health Security track. Her dissertation is on the role of the National Guard in public health emergency response using the COVID-19 pandemic as her case study. So she's got her MPH from Nova Southeastern University, and she's got an MS and a BSc from down in Florida. And prior to her current position, she served in Air National Guard emergency response at the Crisis Action Team Operations Officer for multiple hurricane responses and also the Afghan humanitarian response. And she also spent time at the NIH doing biosafety and biosecurity for their labs, including their high containment labs. And as you can see, she had a really great picture on LinkedIn that I stole for our flyer. So Jamie, thank you so much for coming and speaking with us tonight. And I am going to turn it over to you now.
Okay, thank you, Dr. Elstick. I really appreciate that. So hello, class. My name's Jamie Brooks-Dumproff. I'm a captain in the Air National Guard, and I'm excited to speak to you all today in regards to the National Guard's role in public health emergencies. First, we're going to be a small group, and I want this to be interactive. So if you have questions, please feel free to raise your hand electronically if you have that option. Not sure if you do on these. Okay, or post in the chat, and I will continuously monitor it, and I can pause in between and see if there's any questions before I move on.
I'll watch it for you too, so I'll give you the heads up if anything's in the chat.
Okay, thank you. So this is just an overview of what we're going to talk about today. So she already gave me the nice introduction, so I don't really have to go into that much, but did want to kind of just start off with this picture. So this picture is actually from January 2020. And I was a new officer actually at Medical Officer Boot Camp when the first cruise ship was quarantined right off the coast of the United States in Washington. You can see on my picture, MERS, SARS, in 2019, nCoV on the whiteboard above my head. So 2019 nCoV is what COVID-19 was originally referred to as, which was novel coronavirus. And as I was teaching my new fellow Guard and Reserves medical personnel, I was teaching them about the coronaviruses and different types of coronaviruses, like the 5 that exist normally, in our flora fauna for like colds and et cetera, and the MERS, SARS, and the new one. So just like any other public health emergency, you won't have all the answers, especially in the beginning like this back in January when a new outbreak occurs. But as public health professionals and preparedness, you will give medical intel briefs to your fellow medical coworkers, giving them briefs on what you know, what you don't know, and how to educate them on how to best protect themselves. So I'm not sure how familiar everybody is with the actual National Guard. So I kind of wanted to give a brief overview. Is anybody does anybody really know much about the National Guard or no? Okay, okay, good. Okay, so basically what it is the National Guard is part of the reserve component of the United States Army and United States Air Force. And it's dual controlled by the president and the state governors. So the National Guard is made up of the Army National Guard and the Air National Guard. And for many of the disasters, they work jointly together. So throughout this presentation, when I say National Guard, I'm really referring to both the Army and the Air National Guard because they will tend to work jointly together. So it's important to note that this is the only military organization that's not solely controlled by the president. So active duty is solely controlled by the president. The reserves is solely controlled by the president. But for the Guard, we have 2 bosses. We have the president and we have our state's governor that we serve. So, and most of the members of the Guard are what we call drill status Guard members. This means that they work full time in their state, in their communities as regular civilians in a public or private organization, in your hospitals and policemen, et cetera. And then they only do the military part-time. And our part-time is usually 1 week in a month, 15 days extra of training per year, minimum. And for those unfamiliar with the term civilian, it basically just means for us, anybody that's any people or jobs that are not military is what we consider civilians. And then when an incident occurs within the state, a governor can activate their National Guard members from their part-time status to a full-time status for the emergency response through what is 3 different types of orders. They're state active duty orders, federal Title V, or federal Title 32. Title 32 are the most common type of federal orders because it allows members to continue to fall under both the president and the governor. If they move them to Title 10, that's the same orders as regular active duty and the governor loses control of them. So Title 32 is like a nice spot for when there's a state emergency or city emergency happening. And because it provides the governor the ability to control their Guard resources and their personnel, but it also being on federal, it gives more benefits to the Guardsmen, liability protection and funding compared to SAD orders because that's state funding only.
We have a quick question for you, Jamie. So JD is saying, that when he got his first vaccine, it was all run by the Mississippi Guard. Would that have been ordered on a federal level, or would that have been the Mississippi governor?
So the Guards members that were providing vaccines everywhere are what we call the Title 32 orders, which means that they are federal, but they are still under control of their governor.
Now, when you had people that were activated through the National Guard doing those vaccination centers, were those, like, when Coast Guard members were activated, we were supporting FEMA vaccine sites. Were you guys supporting like FEMA sites, or were you supporting like your own smaller, or not smaller, but like state-run sites?
So I'll go into this a little bit more, but our actual Title 32 funding is FEMA funding. But we fall under, at the sites, the health departments, or the community organizers that's putting it on. If the hospital is putting it on and requests help for us, we are never the incident commander. Incident commander is always a public or private organization, and then we come in. Any other questions before I move on? Okay. So I wanted to do like a quick picture to kind of explain how the Guard is activated from part-time to full-time when an incident occurs. So as you can see here in the three, first, I just want to say this is part of FEMA's National Response Framework. It's part of the NRF. And then off the NRF is the DoD's Defense Support of Civil Authorities process, which is called DSCA. And this is where this falls under, is the DSCA process. And the pre-incident phase, which is right here, it's the planning, the coordination, the exercises. And this is where you want to build your relationships between the Guard, the state, public, and private organizations before an incident occurs. This includes the creation of collaborative disaster plans and training exercises. And then once the incident actually occurs, then the rest of the National Response Framework is followed, which uses a bottom-up disaster response. So it means the first people that get there are your local response, your police, your fire, your emergency medical, your hospitals, and the city, your city officials, et cetera. And then once that local response becomes overwhelmed, the mayor requests support from the state governor. And
Jamie, can you turn your video on and off real quick? Because your audio got really weird all of a sudden.
Oh, okay. Sorry.
Oh, actually, it's better. Whatever you just did.
Oh. Do you want me to just keep my video off for now, or?
It actually got better right before you turned it off. So.
Okay. Sorry about that.
Oh, no problem.
So where was I? Okay. So once the governor is given the green light, they can activate the National Guard then. And at this point, they can activate them in what they call state active duty, which is SAD orders. And then also the other state organizations are activated, like the state emergency management, health departments, and the state agencies. And the governor can also request support from other states via the EMAC agreements, which are emergency management assistant compacts, where, so say I'm the governor of Florida, I may have an EMAC with states nearby like Georgia and Alabama, et cetera, for hurricane response. So basically, if a hurricane hits Florida, I can contact Georgia and be like, hey, can you come and help me? And that's what the EMACs are for. And then once the state resources become overwhelmed, then the governor can request support from the president and the Secretary of Defense. And this request allows the president the option to, one, make an emergency declaration, which then will release federal funds to support the incident. And also a lead federal agency is appointed at that point. Usually it's FEMA. And then they request the support from the SecDef to allow them at that point to go from state orders to federal orders of the Title 32 authority. And And all these steps don't have to like happen once everything is overwhelmed. It doesn't have to be step by step. They could kind of happen simultaneously depending on what the incident is. Any questions? I see there's a few. No? Okay.
Nope, that was just figuring out the audio. I think you're good.
Okay, good.
Actually, Jamie, I do have a question.
Yes.
So how often does this request not go the way the governor would like it to go? Do they get turned, how often do they get turned down or such?
I don't think, I cannot recall a time where specifically the governor can at least do all the way to the state funding and then ask the request for the president. But usually, depending on the incident, a lot of them tend to continue to rely on their EMACs. So for example, a lot of states that are huge on hurricane response or wildfire response, they'll be like, if they start to feel overwhelmed, they'll be like, if it's Louisiana, for example, they'll be like, hey, Texas, can you come help? And Texas will come help. And it'll stay as that. It's only for major incidences where it becomes federalized. Any other questions?
We have a hand up. Dominique has a question.
Can you speak a little bit to the Guard capabilities? Does each state National Guard tend to have a focus and have certain capabilities, or is there across the board uniform capability?
So every Guard unit does have a specific mission. So for example, on the air side, you know, one wing would be a fighter mission where they'll have fighter jets of F-16s or F-32s, et cetera. One place will have cargo planes and they'd be a supply mission. One place also has cargo planes, but they're aero medical evacuation missions mainly. So those will be dependent. However, every Guard, whether it be air or army, does have, for example, a medical group. They all have police, they all have fire department. So those kind of capabilities are still always there in each state. Okay, I'll go on to the next. If anybody, unless anybody else had anything yet. So I wanted to take a brief pause before we go into COVID and kind of talk about the history of Guard responses in the past. So for the purpose of this presentation in general, the subjects of emergency response and public health emergencies tend to be interchangeable during disasters, mainly because ESF number 8, which is the emergency support function, is public health and medical services. And there will always be some type of medical component during a disaster, such as like a medical evacuation. So for the purposes of this entire presentation, when I say public health emergencies, this word interchanges with emergency response. And so the National Guard has played a role throughout history in past emergencies in the US, since its first militia regiments were organized in Massachusetts on December 1636. So for example, here, the National Guard has been active for many, many natural public health emergencies since its inception. For example, there's historical records that exist of the Ohio and the California Guard responding to natural disasters as early as 1903. And the National Guard also has assisted in past chemical and other biological disasters before COVID, such as the Deepwater Horizon oil spill back in 2010. And the Texas National Guard was activated in 1974 to help with an anthrax outbreak that occurred in Texas. So there is familiarity before COVID. It's just COVID's been the largest. And then here's just like a quick brief snapshot of various historical records of natural, chemical, and biological public health emergencies that the Guard has assisted in the US that we have actual documentation on. So as you could see, even as early as 1793, Guard members were activated to help with vaccination of yellow fever, helped with inoculation of smallpox, and then the various hurricanes that you can see on here, lots of hurricanes. Hurricane Katrina in 2005 is pretty much what changed emergency response in the US forever. So for that reason, I wanted to take a more in-depth look at that one first before I moved on. So prior to COVID, Hurricane Katrina was the largest emergency by type that the Guard ever responded to. It still remains the largest response to a natural disaster. It's now the second largest response ever, with over 10,000 Air and Army National Guard activated to assist in Louisiana and Mississippi. And just one example of the Guard's role during Hurricane Katrina was through EMEDS and how they collaborated with their state's public and private organizations. So EMEDS is the Expeditionary Medical Support. And the reason for this was after the hurricane struck, there was only 3 civilian hospitals that remained open and operational throughout both states. And EMEDS is the modern version of, if any of you guys ever seen the old TV show MASH, that's what it is, the Mobile Army Surgical Hospital. So it's basically a mobile small hospital that can provide inpatient care, inpatient surgery, dental, lab, pharmacy, you name it. They basically pick it up and bring it to the site and put it down and set it up. And these medical teams, consist of physicians, nurses, and medics from the Army and Air Guard. And during Katrina, our EMEDS folks worked closely with the FEMA medical teams to care for and transport thousands of victims. They ended up treating over 7,000 patients in New Orleans and 4,000 patients in Mississippi. And specifically, a public health example was the EMEDS flight surgeons. They collaborated with their active duty counterparts and other federal agencies to set up public health clinics in multiple places where the civilian clinics and urgent cares were destroyed by the hurricane. And they also performed public health duties, including environmental assessments of the floodwaters because they were mixed with raw sewage. And they also did mosquito surveillance and insect prevention. And then finally, the Guard also collaborated with the active duty EMEDS at the New Orleans International Airport to support special needs shelters. And they set up a medical facility in the Superdome where they triaged about 5,000 evacuees over a period of 7 days. So lots of people. And over 30,000 hurricane victims received medical treatment through EMEDS, whether it be Guard, active duty, et cetera. And it just represents one way that the Guard can be used to help a state's public and private organizations during a disaster. Any questions so far? I see, Dominique, you still have your hand up. Okay.
Sorry about that. I'll take it down.
It's okay. All right, so now we're going to go into COVID. And it's now the largest response to a public health emergency by type by the Guard in both terms of time frame and total number of resources, manpower, and supplies. All 54 states and territories used their Guard during at least one portion of the pandemic time frame. And there were a variety of ways they did it. And as you can see in this graph, the largest time, the largest total activation was at the beginning of the pandemic. And it was about over 45,000 Guardsmen were activated to help in their states across the US. And then here's a little screenshot, a graph of the types of missions that the Guard's done throughout this whole process by the number of states. So for example, for testing and screening, there were 35 states that have used their National Guard to do COVID testing and screening. There were 24 states that used their National Guard for vaccine support to civilians. I know you had mentioned earlier about the ones asking about the support, that your state was not alone. There's about 24 of them. 21 states use their folks for hospital support, primarily for like admin duties only. And as you see here, also 11 states use their folks for medical hospital support. And 3 states right here used it for mortuary affairs. The biggest state was New York. That was when they had their large outbreak back in spring 2020. They collaborated with the city's mortuary affairs to help in that. And actually, primarily, it was interesting was the city's mortuary affairs focused on the COVID patients, and they had the guardsmen helping with the other types of deaths so that the city could then focus specifically on the COVID deaths. So now I'll spend the rest of this presentation going through some specific examples of a few of the medical missions the Guards assisted with during the pandemic. And so because I was the West Virginia Guard epidemiologist when this first started for over a year, a lot of these examples will be from my own, but I do also have included a couple of other Guard states. So one of the ways that some of the states use the Guard was to assist their local and state health departments with responding to large COVID outbreaks at the beginning. So for example, in April 2020, in response to rising nursing home outbreaks, our governor in West Virginia ordered COVID testing of all nursing home residents and staff across the 124 nursing homes within the state. And this came out to approximately 28,000 COVID tests. And the tests were done primarily to help prevent more disease and death among the nursing home residents. And they were actually the first state to do so before the CDC made it a requirement for all states. And the West Virginia Guard assisted the state and local health departments with both the testing of the staff as well as outbreak investigations. And what we call spot maps were used in the outbreak investigation to compare groups of positive patients' locations, as well as to identify and focus on outliers. So as you can see in the picture here, that this is actually me back when I was a lieutenant. And we have a little spot map of one of the nursing homes that we did our investigation for. And it was a 1-level only nursing home with 1 hallway. As you see, there's 2 entrances and exits, and there's 1 hallway that connected all the rooms together. And you see this DX, that was the first diagnosed patient. So in this case, this patient, the only COVID symptom he had was he was having diarrhea issues. And the nurses would go in and they would clean him up. However, microscopic contamination occurred, fecal matter onto the floors. So when they would finish cleaning up the patient, they would then go into the adjacent rooms, and each of these is a room of a nursing home. And these rooms became infected with COVID from the fecal COVID transmission. And we also, when we did this investigation, had this 1 room over here, which was completely away from the rest of the rooms, where this patient also became diagnosed with COVID. And we were trying to figure out, how did this person on the opposite side of the building also come down with COVID? because they had different nursing staff as well. So it wasn't the nursing staff that treated the diagnosed person. It was completely separate staff on this side of the floor. And we found out through the interviews and then drawing the spot map is what this patient did was every day, about 3 times a day, would leave her room and walk circularly around the hallways. And based on that, we think the person became contaminated when the fecal matter on the hallway got kicked up while they were walking, and that's how they got it. So this was just an interesting way, and a way that we collaborated with their local health department and the nursing home to kind of figure out the outbreaks and the causes. So the next thing is contact tracing. Some states use their GARD for contact tracing as well. And this was completely within the health departments, local health departments. So the GARD members would work inside the health departments and call the patients for contact tracing. And contact tracing is a very common public health measure that's been used throughout history. COVID is not the first one. And it consists of contacting people who test positive from an infectious disease and then collecting data from that patient that they provide to us voluntarily. And then we also ask them about their contacts. So depending on the infectious disease is dependent on when the time frame is somebody is considered a contact. So for COVID, for example, a contact was always 2 days before they show symptoms, if they're symptomatic, or 2 days before a COVID test, if they were asymptomatic, and then while they were symptomatic with COVID. And we would collect these contacts and call them. And the whole purpose of contact tracing is to try to limit the spread by quickly contacting the people who are infected so that they know to isolate and to educate them on how to isolate properly, and also to contact their contacts so that they can quarantine and also go get tested to try to limit the spread, break the chain of infection. And for example, Iowa GARD and Pennsylvania GARD, which is actually shown here, were trained with their local health departments, and basically they were for surge capacity. So when the amount of positive cases became too overwhelming for the small health department staff to keep up with themselves, they brought in the GARD to help them. And it's important because the more manpower you have, the quicker you can call the patients, the quicker they can isolate, and the quicker we can, help with the spread. So if you are in Pennsylvania and you were ever contacted by a contact tracer, it might have been a Pennsylvania National Guardsman who called you, or wherever state you're from. So in West Virginia, we actually not only did the contact tracing, we also collaborated with West Virginia University to teach a 3-week online contact tracing course during the summer of 2020 to public health and medical undergrad and graduate students. And we ended up in 3 months training over 300 volunteers. So then the health departments had 300 volunteers workforce to go help them with contact tracing. And I'm going to take a pause. Is there any questions before I keep going?
I'm just curious, did the National Guard reach out to the university, or was there an established relationship, or do you know how that happened?
So West Virginia is kind of interesting in that the governor would always do, even from pretty much the beginning, the governor would have press conferences with all the major players that were responding to COVID. So he had at his table, he had the health department person, he had a National Guard person himself, and then his COVID czar, is what they called it, was actually the medical director of West Virginia University. So he was always there too. So that's kind of how that began. And through so all the health department, WVU, the Guard, were always collaborating. And then we also collaborated with like the hospitals and community groups, churches, etc. So it was really interesting.
It sounds it.
Yeah. So another big thing that one of the biggest missions that the Guards did was COVID testing. And they were used a lot for this for the health departments, primarily because, as we know, health departments are underfunded, they're short-staffed, and they didn't have enough capability to respond to a pandemic with the staff that they had. So pretty much the Guard came in to give them more manpower. And one of the biggest things that we focused on, at least in West Virginia, was testing our vulnerable populations. So we specifically targeted our counties with high rural and high minority populations. And this was, the reason for this was, as we know, there's longstanding health inequities that make these populations more vulnerable in the state to severe disease, hospitalization, and death of COVID. So we really wanted to focus on these groups. And we specifically collaborated with the Office of Minority Affairs to specifically hit our minority towns. And we collaborated with our local health departments to specifically hit our rural populations. And kind of how it worked was the WVDHHR, that's our state health department, they would select a county for the testing site in collaboration with the Office of Minority Affairs to try to target the minorities in the county. And then the state would notify the county the date and time to have the testing site, and the location was determined in collaboration with the local health department because they know their county the best. So they picked the site based on what the state and the Minority Affairs Office was targeting. And then the state, the county, the governor's office, et cetera, coordinated the advertising, whether it was by press conference in the news, by signage, et cetera. And then they identified, the local health department determined, did they need extra help or not? And if they did, they would route an assistance request to the state. And then the state health department would contact the Guard and be like, hey, we need people at this location, or hey, we need supplies at this location, and would deploy them. And we would be able to respond within 24 to 48 hours to the location. And that's, and just shown in the picture is one of our testing of me. We were in shorts that day because it was hot. It's June 2020. But we also had mobile testing vans for our really rural communities, because West Virginia has a lot of rural communities. So we would take the testing van to these areas and do the rapid testing so that the citizens would get their results within minutes. And we ended up, our team conducted analysis actually of our testing sites. And these are the results that we had. So a total of over 1 million tests were conducted in West Virginia from May 22nd to December 30th, whether it was through our testing sites, the pharmacies, the health departments, et cetera. But the specific partnership between the Guard, our health departments, and other partner organizations that we collaborated with, our sites did a total of 98,000 of the COVID tests out of the 1 million. And we did 512 testing sites total throughout the state. And that equated to about 7% of all COVID tests done within the state. And it resulted in the National Guard being the leading outside partner organization for total number of people tested. The second organization after us was WVU. because they have lots of WVUs, not just in the university, they also have hospitals throughout the state and et cetera, that they were able to test. And then this is just a graph breakdown of our percentages of counties based on whether it was a rural county, a minority identified county, or rural and minority identified. So 349 of our testing sites occurred in a high rural population, a high minority, or both. And of these testing sites, 186 of them occurred in a rural population, 134 in a minority population, and 30 in both of them. And as you can see in the month of November, we had the most testing sites events that month. We had 217 of the 512. So almost half of all of our testing sites were done that month. And 96 of them, which was about 44%, was done in a rural county. And 40 of them, which was about 18%, was done in a minority identified county. And 3 were in both. But the month of October, right here, had the highest when it came to rural identified counties tested. And the months of May and September had the highest for a minority identified. And these results were published recently in the Journal of Health Security for that. Oh, go back again. All right, so vaccine distribution. So this was our second largest mission that we did. And one of the biggest things that came to light back in January 2021 was the challenge of how do these states get all these vaccines from manufacturer shipment to the patient into the arms. And many health departments were really taxed at this point with the pandemic. So a lot of them started to use the National Guard specifically for this, which was great because the National Guard's really good at large scale logistics. We can move people and supplies to pretty much any location in the world within 24 to 72 hours. So using them in a logistics capacity at least is a key military strength, highly recommend for any other emergency. And I know we're starting to come out of time, so I'm going to go a little faster, but just kind of wanted to talk about basically in West Virginia, we had hubs. So we did 5 hubs throughout the state, and it was all within a 2-hour driving distance from the hub to the testing site. And what people would do is the health department would contact us and have their representative come to the hub, pick up their supplies, and then go. And because of this, we actually led the nation in putting shots in arms back in January 2021 because of this logistics process. And then finally, for COVID vaccinations, 24 of the states and territories throughout the US, so almost half, use their Guard for vaccinations. The Guard has helped to administer at the health departments or other places over 15 million vaccines to the public. And over 500 million doses so far have been administered over nationwide. So about 3% of all vaccines administered in the US, the Guard had helped in some capacity. Many of the states also, just like the testing, focused on health equity. A lot of them had mobile vaccine teams that would go into the small and underserved communities, the rural populations, et cetera. For example, Mississippi National Guard, they would go into the rural areas to help with vaccinations. And the Maryland Guard collaborated with multiple public health partners, and they conducted over 60% of their vaccines on underserved communities. And then finally, the last thing I wanted to touch on was hospital surge capacity due to Omicron. So in January 2022, hospitals across the US were asking for help because of the Omicron patient surge and staffing shortages in the hospitals. So the president actually expanded their FEMA policy to allow the Guard to go help the hospitals. And 28 states and territories used that FEMA funding, and over 6,000 Guardsmen went and helped hospitals throughout the nation. And although some states use their medical people, it was mainly a non-clinical support because we were trying not to, take from Peter to serve Paul kind of thing. We wanted to keep our medical folks in their hospitals if they did that on the full-time side. So primarily we helped in non-clinical ways, such as cleaning patient rooms, delivering trays, greeting patients, et cetera. And then in the hospitals, Guard members usually wore their uniform or they wore scrubs depending on their duties. So for example, in this picture here, the person's wearing the uniform because he's actually a supervisor capacity there, and the person in the scrubs is there in a medical capacity. So he actually has his olive colored shirt underneath his scrubs to help identify him. And patients may not know that they're being cared for by Guardsmen, but once they found out, from what I've seen or what I've read, most of them have always been very interested and appreciative that they're there. And then because the Guard is unique in that they usually live within the state they serve, a lot of the Guardsmen really have enjoyed being able to serve in their local communities, because most of the time, if they're activated to go overseas. So it's nice to be able to give back to the place where they live. And then the hospital staff was also really appreciative because it helped with extra support, it helped to boost morale. And one even commented saying that, it's nice to know that we're not alone in the fight. It's been almost 2 years, and it's nice to have help. Sorry. So I wanted to end my last slide on the COVID orders are ending. A lot of states are already done, but the total orders are ending on June 1st. And I wanted to end it by saying that, like a lot of you, I'm also a grad student. I'm a doctor of public health candidate. So my dissertation is specifically on, what can we learn from this? What collaborations do we need to keep? How do we maintain these relationships? Because I know when we started, we didn't have a relationship with our health departments. And that was a common thing throughout almost all the states. And so it took time to build these relationships. It took about a month to build trust and et cetera in the state health department. It took longer in local health departments. And there will be disasters that occur that we don't have that kind of time. So what's the best way to maintain these public and private organizations for future public health emergencies? And I'll be interviewing 20 states, Guard people, health department people, and rewriting actual Air Force and Guard public health policy documents so that we're prepared for the next one. So any questions? That's the end of my presentation.
We've got a couple in the chat. I'm going to do Dr. Langrich's first because I know he's got to leave at 9 o'clock. So I'm wondering about the training of the National Guard for emergency response. Is it incident command? Oh, actually, he's got his hand raised, so I'll let you take it.
Yeah, Jamie, that was very, very good. Thanks. I learned a lot, not only about the National Guard, but sort of about your overall response. So thanks a lot. Yeah, and thank you for your service as well. I really appreciate that, learning more about it. I guess the question has to do more with, and maybe you sort of are addressing it with what you're doing with your DRPH program, but what's the training like? What kind of training do you get in being a Guard member particularly for public health emergency situations. So, we talk a lot about all hazard training. We talk about communications. We talk about incident command structures, things like that. So it seems like you get pretty general training to be able to respond to as many crises as you might get faced with. Yeah, and then I guess sort of a follow-up question is, what do you wish you had learned in your MPH program or your training program that would have been helpful for you in this area?
Okay. So as a public health officer, they mainly rely on your MPH, and then you also do a 3-month training in Wright-Patterson, Ohio, on the general public health programs that we run. And there's not a lot specifically on disaster response. There are in the Guard specific teams that are created to respond to all hazards, whether it be a sea burn event, et cetera. In West Virginia, we have a SURF-P team, which is a medical team composed of doctors, nurses, et cetera, that actually respond if anything was to happen in DC. So they always go to the inaugurations, for example, the State of the Unions. If there was an incident to happen, they are there to respond to that in a medical capacity. We also have our CST teams, which are mainly the Army, and they help with chemicals, disasters, et cetera. And we also have our security teams and et cetera, our DMORT teams for mortuary affairs and anything like that. Those are our specialized teams, but the average National Guardsman, it is a limited training.
Yeah, and any, sometimes we see people in our public health preparedness program or other public health training programs who want to go into this. Is there any guidance or particular training you wish you had before doing this?
I believe a lot of the FEMA trainings were really helpful for me. I really enjoyed them and they helped to that.
Good. Okay. Thank you. Thank you. I apologize. I do have to go to another meeting at 9 o'clock. So, but again, thanks, Jen. Thanks, Jamie. This has been great.
It looks like we have a hand up from Dominique again.
Yeah, I just wanted to, I'm an emergency medicine physician in Huntington, and I just wanted to add that we've had a good relationship with the Guard in the past, probably through connection I have from our emergency management, our local Homeland Security group. Started with decon shower training from the SURF-P and CST. And then when this happened and we were looking for PPE and looking into getting testing, your chart shows the amount of testing that you helped with early on. And I believe at that time, there was a lot of trouble getting any testing done on COVID and the first month or two that you showed in your graph. And so those relationships were invaluable. We did donning doffing training with them when COVID first hit. They came into our hospital and looked at our layout, helped us set up hot, warm, and cold zones in our hospital. And so it was really fabulous interaction to have with them. And we're continuing to work on other projects together. So I guess it's a long way of saying that was an excellent training that was afforded to us as practitioners in the hospital. And are there any formal plans that you're aware of that are in place to help build these civilian Guard relationships, or to continue the relationships that were built with this?
Yeah, that's kind of what I'm doing my work on is trying to, keep these relationships. My hope is that we can go into something where, we can pick at least semi-annually or something, one county in each state and all train together and to do some kind of response training and bring the local hospital, the local health department, the guards, everybody that would come and respond normally and do a training together. And also my hope is to also create almost like a liaison person that you have some kind of point of contact that we can keep in touch and keep these relationships going. But I also, ask for any advice yourselves.
Yeah, I would have to, I don't want to monopolize the conversation here, but I would have to say that a lot of practitioners are not trained in ongoing, like long running disasters like a pandemic. Many of them aren't actually, formally well trained in chemical response, mass casualty response. And while each hospital, because of Medicaid, Medicare, has a requirement to participate in a community exercise, but it's very general in the requirement. So it can be the requirement can be loosely met with minimal cooperation. On the other hand, it also gives you the opportunity to say, hey, we can come in and work with you so that you can fully meet this requirement put out there by Medicaid, Medicare. So might be an interesting avenue.
Thank you. Definitely wrote that down.
Just very quickly, Jamie, thank you for your services and this wonderful talk. I learned a lot. And so my question is that, is there any plan in your positions that when you foresee the future's need, that the National Guards members and the state governments or local agencies need to work together? Is there any plan that you can start to kind of having some kind of a military exercise or drill or something like that and a simulation? I believe that a couple of years ago, and you probably noticed better than I do because of your affiliation with Hopkins now. Long time ago, when I was at Hopkins, that I know that there's the first plan in the nation that would come up with this public health preparedness exercise there. That's coming from Johns Hopkins Institution. So is there any plan like that? And I think that would be very valuable. So can you share some light that is there any plan like that?
So there's actually a requirement for the Guard and military in general that they exercise a disease containment plan annually. And a lot of times these are just tabletops only with the Guard members, et cetera. And my plan, my hope is that we expand that into including our representatives from the health departments, from the hospitals, the pharmacies, et cetera, when we do these exercises, kind of similar to what Dominique mentioned for the Medicaid, Medicare. We all have to do this anyways. Why are we siloing ourselves? We should, include as many of the players that you would be working with as possible.
Thank you.
I would recommend when you start to do that, again, just being from the civilian sector side of it. I mean, I have an interest in disaster medicine, and so I ended up chairing our disaster preparedness committee on the hospital, which means I started it because there really isn't anything in the hospital for that. And it seems, just with my colleagues around the state, that there isn't a lot of training in that. So when you bring people together for an exercise, it would be a challenge for sure, because of resources on the hospital side of things. And also, you want a chance to showcase what you are able to do, but if you haven't had a good chance to exercise or walk through the process, or don't have the training to understand what's required in a disaster response, there may not, it's difficult to fully participate. One conversation I've had, actually, it turns out, with the Guard on a joint training involved time over the course of the year to get all of the departments trained up so they actually could participate in a useful manner instead of just sort of being blindsided by something that they aren't trained in.
I know we went over, but anything else?
I had one more quick question if you still have a few minutes. I was just wondering what you think about the sustainability of relying on the National Guard for something like this, because I know, like, being in the Coast Guard, and I saw how many people we activated to support FEMA. And I just keep coming back to, what if we had a COVID-like incident following a 9/11 type incident? Or what if it happened during a Hurricane Katrina or a Deepwater Horizon incident? I mean, there were so many coasties activated for both of those. And I mean, the National Guard's amazing and you guys can do so much. And the Coast Guard is amazing. And the people that I work with are super adaptable. But both of those are just, I mean, regardless of how adaptable they are, they're both finite resources. So it makes me, like, it's amazing to see all the great stuff that they did, but it makes me nervous that we did use them so much during this. And looking at it, I appreciate it, but I also don't want to become too reliant, like, oh, well, we can do this next time, because we don't know what the rest of the situation is going to look like next time. So, I mean, do you think that's kind of a risk, or how do you approach something like that?
Yeah, so COVID was definitely a learning opportunity for the Guard, because this is the longest the Guard has ever been activated federally in US history. The second longest was for Katrina, and that was, I believe it was 8 months at the most, 6 to 8 months, with cleanup and everything. And honestly, the Guard, like I said, most of them are drill status guardsmen. They have full-time jobs on the outside. So a lot of them aren't able to just drop their jobs and come and be activated for months at a time. And we did have a lot of rotations and et cetera. But at the end of the day, the Guard is supposed to be for surge capacity. So what really needs to be done, which I will not have any control over, but what really needs to be done is a larger public health infrastructure at the health departments, at the state and the local level, more manning there, more manpower there full time, so that when another pandemic happens or outbreak happens, and it will happen again in our lifetime, we are way too connected. There is way too many animal to human viruses that exist. It will happen again. And we need to be better prepared as a country for the next big one.
Sounds good. I know it's 9:07, so I don't want to keep you too long. Does anybody else have any parting questions, comments, or anything for Jamie? It doesn't look like it. Thank you so much for taking your time to come talk to us tonight. I know you left another meeting so that way you would be able to come. So I really appreciate you doing this. I love seeing all the great stuff that you post on LinkedIn. And when I love getting speakers from LinkedIn. Everybody has been so great when you tell them that it's for a school program. And I came across something that you had posted, and then when you and I connected, and I love seeing all your COVID articles and everything. So I appreciate everything you're posting, and I really do appreciate you taking your time tonight. So thank you so much.
Thank you. And thank you all for having me. And on that comment, if you want to find me on LinkedIn, I am probably the only Jamie Brookstuff Prof, and you can go ahead and follow me.
Well, have a great night, everybody. Those of you who we're seeing at graduation or the IAEM meeting, we'll see you soon. If not, we'll see you back here in September. And Jamie, best of luck to you, both of your oral exams. So I'll be keeping my fingers crossed and looking forward to hearing about it on LinkedIn.
Thank you. Have a good day.
Have a great night.
Good night, everybody.
Bye.